Hey again, everyone. Milkman Al here. One of the most common things that I am asked day to day is, "Hey doc, what are you gonna give me to put me out? Are you gonna give me any of that Michael Jackson drug?" Well, yeah, I'm probably gonna give you a whole lot of it actually. So we use it a little more responsibly than he did, but it still does the trick. Generally speaking, anesthesia is really safe, and we can use fairly formulaic mixture of things to get people to sleep. Typically, we use a medication called fentanyl, which you're probably familiar with for pain. Propofol, which is, quote, the Michael Jackson drug. A medication called Versed or midazolam to make you forget. And then we keep you asleep with a gas, usually called sevoflurane. That works for the vast majority of people. But what if it doesn't? What if that's not a good choice? What if you need to change your plan? That is what we're going to be talking about today. But before we get into it, don't forget to like and subscribe here and follow me live 8 to 10 p.m. Central on Wednesdays and Sundays, and come join our Discord. Come hang out and chat. Right, so like I mentioned, usually we use a cocktail of things to get you to sleep. Typically, we give people Versed, like I said, in the pre-op area to relax them, and it's a very good amnestic, which means you basically forget most things or everything that happens after you get the medication, and it acts pretty quickly and lasts, maybe a couple hours or so, at least for the duration of your surgery, or until we can get you other medications that are also amnestic. Because nobody really wants to be remembering surgery, right? So you get Versed up ahead of time, and then we'll take you back into the operating room, get all of your monitors and all that sort of stuff on you. And then we start giving you pain medications. So specifically, we'll give you fentanyl up front to basically get on board. It takes about 5 minutes to start working. And presumably that dose that we give you will still be working when they make surgical incision. So your response to that incision will be blunted. Also, we're going to put a breathing tube in your mouth, and that's really stimulating and generally kind of painful in itself. So we want the fentanyl to be there to sort of calm that response down too. So we've got Versed, fentanyl. We'll give you some lidocaine, which also serves the same purpose. When you inject lidocaine IV, it's also a bit of an anesthetic and helps you be more comfortable, helps your cardiovascular system during induction of anesthesia. Speaking of induction of anesthesia, that's kind of the gist of this talk. So, as I mentioned, most people get Propofol. Propofol is a very safe drug. It's nice to use because it hits really fast and it wears off really quickly too. So if you screw up and you give somebody way too much of it, the effects are gone in like 10 minutes or so. So you don't really have to worry too much about it. Obviously, you need to use it very carefully because it does have some pretty profound side effects. As I alluded to in the intro, it gained some popularity, or at least notoriety, for its role in Michael Jackson's death. So, Propofol can lower your blood pressure pretty profoundly, and for some people, that's a huge problem. Like if they're already tenuous to begin with, that you can't really afford that drop in blood pressure, so you have to be really careful. It also makes you stop breathing. So if you get, which is what got Michael Jackson, because he had a continuous infusion of it, so there wasn't an opportunity for it to wear off, right? So he got too much propofol, stopped breathing, and the propofol just kept coming. So he suffocated. You have to be prepared for that. And in a lot of cases, that's actually what you want, because it makes it easier to put a breathing tube in somebody when they're not breathing. And in fact, we'll often give you a paralytic medication to make sure that your vocal cords are open and not moving so we can put the breathing tube in more easily. So Propofol is kind of our default. It's easy, like I said, easy to use. It's generally, pretty well tolerated in most people, even like moderately unhealthy people. And it's generally pretty easy to dose. Most people take anywhere between 1 to 2 milligrams per kilo. One of my staff in training used to tell me 70 gets you 70, which means if you're 70 years old, you get 70 milligrams of Propofol to start with, regardless of how healthy you are. Anesthesia does hit you harder as you age, and so therefore you kind of have to tailor your dose with the elderly people. That's just sort of one of the arts of medicine rather than the science. So what happens if you can't use propofol? Where do you go? What's your choice? So there are two other main medications that I personally use, and then we'll talk about a third special case. First off, we should talk about what exactly is general anesthesia and what are these induction medicines? The American Society of Anesthesiologists defined general anesthesia as a drug-induced loss of consciousness during which patients are not arousable, even by painful stimulation. The ability to independently maintain ventilatory function is often impaired. Like I said, propofol can make you stop breathing. Patients often require assistance in maintaining a patent airway, and positive pressure ventilation, that is, mechanical ventilation, may be required because of depressed spontaneous ventilation or drug-induced depression of neuromuscular function. Cardiovascular function may be impaired. So that's basically all the things that I just talked about with propofol, right? It can make you stop breathing, it can lower your blood pressure, and sometimes if your heart is sort of borderline, it doesn't really like that low blood pressure because it's not that your heart isn't getting the blood flow that it requires. So if we scroll up here just a touch, there's a continuum of sedation that they have listed here. So this sort of summarizes that definition that they gave us. So unarousable even with painful stimulus, intervention often required for airway maintenance, spontaneous ventilation is frequently inadequate, and cardiovascular function may be impaired. And I'll link this in the description just in case you're curious. So, if we're not using propofol, we need to do something else to achieve this condition, right? So, we have our cocktail of meds. Propofol is very, very good at inducing what we technically refer to as anesthesia, which means lack of sensation for your environment. But it is not an analgesic, which is why we give fentanyl and lidocaine. Those are very good analgesics, that is, pain meds, while propofol is a very good amnestic while it's on board because you're anesthetized. It doesn't last very long, and that's why we want the Versed or midazolam to sort of bridge you to the point where you're breathing the anesthetic gas, which is in fact an amnestic in itself. So basically, we're looking for drugs that have a similar profile to propofol, right? We want things that work quickly, that last long enough for us to do our job, that is to say, make sure we can ventilate you, place a breathing tube, and get you hooked up to mechanical ventilation so that you're breathing the anesthetic gas. And there are two other main options for that, like I mentioned. So the first is actually my favorite drug, ketamine. I freaking love ketamine. It is amazing. So there's new research that it's good for depression. There's a lot of mental health uses for ketamine. So what ketamine is it's actually in the same class of drugs as PCP. It is an NMDA receptor antagonist. That is useless information for the vast majority of you, but in case you're curious, that's what it does. Other NMDA receptor antagonists that you may not know about are DXM in cough syrups, dextromethorphan, and magnesium, oddly enough. So anyway, ketamine is super duper nice because it maintains heart rate. In fact, it increases people's heart rate a little bit. It's a very strong analgesic. So unlike propofol, it can kill pain on its own. And in fact, we use it in small doses for pain control really readily. And that's one of the things that I like the most about it, is it's very, very effective for pain control. And in big enough doses, in anesthetic induction doses, it makes you immobile and essentially chills you out enough for anesthesia to take place. The problem is it is not an amnestic, or not a very good one at the very least. So you need something to go with it. Usually if you give somebody Versed prior to having ketamine, that's enough to do the trick. It also has a nice side effect of largely preventing the hallucinations that come with ketamine. Because like PCP, it can make you see and hear and experience crazy shit. So if you get Versed on board, at the very least, people don't remember those hallucinations, so that's very nice. You have to watch out with ketamine in the elderly population, as we mentioned, because they do get delirious and kind of go nuts with it sometimes, so be very careful with that. But ketamine is a great drug to use for anesthetic induction in patients who are unstable, because again, it maintains your heart rate, maintains your blood pressure, does not drop your blood pressure like propofol does, and it also, most importantly, maintains your respiratory drive. So no matter how much ketamine you get, pretty much, you're not going to stop breathing. And that is super duper crazy useful. So for people who are what we call a difficult airway, which means that you may require some like video fuckery basically to like get your airway secured. Like maybe you've had throat injury or like throat cancer or something and you've had surgeries in your mouth. Maybe you just have a really weird facial structure. That happens. And it's difficult to put a breathing tube in you. In those cases, we do something called an awake intubation, which is kind of a misnomer because you're not really awake, you're really heavily sedated, but you're still breathing and you're not technically under general anesthesia. But we can use ketamine to anesthetize you and keep you breathing. So if for whatever reason we can't get your airway, you're still breathing. That's fine. We didn't paralyze you. We didn't knock out your respiratory drive and, get ourselves up shit creek where now we have to figure out a way to ventilate this person who's a difficult airway and possibly difficult to mask ventilate. And that's a big problem. So you can just avoid that entirely with ketamine. So again, drawbacks of ketamine, makes you hallucinate, also increases your heart rate, and it can make you kind of nauseated because it increases like mucus sedations or secretions. So sometimes that's pretty unpleasant for people. They can have a kind of a wet cough afterwards, and maybe it's slightly bigger risk for aspirating because of it. But yeah, ketamine is a great option. And that said, a big drawback for it is that it is a direct cardiac depressant. That is to say, if your heart is kind of marginally functional, ketamine is going to stress it out. Like I said, it does increase your heart rate, make your heart work a little harder, and it depresses cardiac function. So if you got a bad heart and you're unstable, this is probably not the drug for you. That is where the third drug comes in. And that drug is etomidate. Etomidate is super duper useful for extremely unstable people with bad hearts. Now, I am personally pretty sparing with my use of etomidate. I feel like it's kind of a niche drug, basically only useful for people who have really bad hearts and are unstable. It has some pretty significant drawbacks, one of which it burns like hell when you inject it. Now, Propofol burns moderately. Some people complain that it's, really unpleasant, but etomidate burns like fucking hellfire. It is extremely unpleasant for the patient. Also, it causes nausea real bad, so people are very nauseated after they get a dose of etomidate. That said, it's better to be nauseated than dead, and induction of anesthesia is probably one of the most dangerous points in my job, at least, especially for people who will be getting etomidate. Now, the main reason that I personally do not use etomidate, except in these sort of fringe cases, is that it can do something called adrenal suppression. And there's been evidence that even one dose of etomidate can do that, even though the studies were mostly for people who got etomidate infusions in the ICU to keep them sedated there. Now, what that means in real terms is you have a gland that's kind of next to your kidneys called your adrenal gland, and it secretes a whole bunch of stuff that's really important for your body function. But one of the things that it secretes, or two of the things it secretes, are chemicals called epinephrine, which you're probably familiar with, and norepinephrine. And both of those are very important for maintaining your blood pressure. Now, if your blood pressure is already unstable and you're in a position where etomidate is a good option for anesthesia induction for you, then your adrenal glands are kind of maxed out already. So if you suppress those, you're doing your patient a big disservice potentially, right? Because you're basically compromising their ability to compensate for whatever stress is happening to their body, whether they're bleeding out or they're septic or, who knows, their heart's failing, whatever. Whatever's going on, you're basically taking their adrenal glands' ability to compensate for that problem down a notch. And I don't like that. I don't like that. I would like to avoid that if at all possible. But, again, there are times where you got no choice. And this is a great drug for those times. It's very safe, again, very easy to use. But I just try to avoid it where I can because, again, it's very unpleasant for the patient experience. And you also run that small chance of knocking out your patient's compensatory abilities. So I said earlier that there would be a final sort of fringe case, and this is the scariest one of all of them. So if you are truly unstable, gunshot wound to the chest, bleeding out actively, totally unstable, and an option for anesthesia induction is, drumroll please, nothing. We can start doing surgery on you if you are sick enough and you're out of it enough with zero anesthesia on board. That does happen because there's nothing that you can give safely to anesthetize that patient. Now, we progress pretty quickly to just giving you a big dose of some benzo, which means Versed, like I mentioned earlier, or a longer-acting benzodiazepine like lorazepam or something like that. that makes you amnestic, but there's no analgesia. There's not really much else going on there. It's just a relaxing med. So as your condition improves, as they fix whatever bleeding or acute condition is causing you to be that unstable to where you can receive literally no anesthesia at all, as we fix that, we can sort of progressively give you more meds. We can give you some pain meds, work that in, and see how you do. We can hook you up to, well, you'll be hooked up to the ventilator if you're in that position, but we can start bleeding in some gas, so you're amnestic and you're truly anesthetized, and basically we can work our way up to a normal anesthetic from nothing, basically. So obviously we try not to do that. We don't want people remembering their surgery, but if it's not safe to give you things, then we can't do it. The reason that it would not be safe is that pain, as you might expect, raises your blood pressure, it raises your heart rate. So if we sedate you and make your pain go away, sometimes that increase in, vascular tension, that increase in blood pressure that the pain is causing, is important to keep you alive. And if we remove that, that's a big problem. So we don't want that. That's really dangerous sometimes. So again, we kind of play it by ear, and you anesthetize the patient as much as they can reasonably tolerate, and hopefully save their lives. Usually that works out, to be honest. That's how it goes. That's how you anesthetize somebody. Hopefully that was useful information. If you have any questions, please don't hesitate to DM me. Leave a comment, whatever. Again, I am Milkman Al. Please come and hang out with us live, 8 to 10 Central, Wednesdays and Sundays. New YouTube videos every Tuesday morning at 9 a.m. Central. So I will see you next week, folks. Have a great one.